All right, today we're going to tackle a really important topic, head and neck cancer. This is a super high yield primer, especially for all you trainees out there. We're talking about the core stuff you absolutely need to know for your rotations and, yeah, for your exams too. So let's just jump right in.
So let's start with a classic scenario, one that should make your clinical spidey senses tingle every single time. A patient walks in with a painless neck mass. Now, why is that such a big deal? Why is this one of the most concerning things we see? Well, because it's a hallmark presentation for head and neck cancer. And really getting a handle on the why here, that's the key to catching this early.
Okay, so what is this cancer, really? Well, the vast majority of these cases fall under one big umbrella, squamous cell carcinoma. You'll hear it called SCC all the time. This is a cancer that grows from the lining of the head and neck region. Think of it as the skin on the inside of your mouth, your throat, your voice box. So, bottom line for you, when you hear head and neck cancer, your brain should immediately go to SCC. They're almost synonymous in this context.
So, where exactly are we looking for this stuff? Let's do a super quick tour of the neighborhood. We're talking about the oral cavity, your mouth. Then there's the oropharynx, which is where your tonsils and the back of your tongue hang out. Go a little higher up, behind the nose, and you've got the nasopharynx. And then down lower, the hypopharynx, and of course, the larynx, which is your voice box. These are the main hotspots you've got to keep on your radar.
All right, let's talk risk factors. The classic villains, right? Tobacco and alcohol. Everyone knows that. But here's the kicker, and this is so important to understand. It's not just 1 + 1 = 2. The risk is synergistic. That means when you combine them, the danger doesn't just add up, it multiplies. It's like they're a tag team that's way more dangerous together than either one could ever be alone.
But there's a new player on the scene that has totally changed the game. And I'm talking about HPV, the human papillomavirus. You absolutely have to get this distinction. Cancers caused by HPV, which we see a lot in the oropharynx, are a completely different beast. The prognosis is so much better than the traditional cancers we just talked about. I mean, the difference is so huge, we actually have to use a completely separate staging system for them. That's how different they are.
And this right here really drives the point home. If you've got an HPV-positive cancer and you're not a smoker, your prognosis is way, way better. It's one of the most powerful predictors we have. This single piece of information can completely change the entire conversation you have with a patient about their future. It's that big of a deal.
All right, so you've got a patient in front of you, and something seems off. You're suspicious. So what's next? Let's walk through the clinical workup. We'll go step by step from that first hint of suspicion all the way to a final diagnosis. Okay, let's circle back to that painless neck mass. How do you start to tell if it's something scary or just a run-of-the-mill infection? Well, think about it. An infected lymph node, right? It usually pops up fast, it's warm, it hurts when you touch it, and the patient probably just had a cold. But a malignant mass, that's the opposite. It's often been growing slowly, it doesn't hurt, it feels firm, kind of rubbery, and it feels stuck, like it's anchored down, and there's no obvious infection to explain it away.
And I really want to pause on this for a second because this is pure gold. This is your classic bread and butter clinical pearl. If you remember nothing else from this physical exam section, remember this. The words painless, firm, and fixed. Those 3 words should set off every alarm bell in your head. That is cancer until proven otherwise. Seriously, burn that into your brain.
So what's the actual pathway look like? It's pretty logical, step by step. First, you do your thing, a good history and physical exam. If your gut is telling you something's wrong, your very next move is an urgent referral to an otolaryngologist, an ENT surgeon. From there, they'll probably do what's called a fine needle aspiration, or FNA, to actually get some cells for a diagnosis. Once cancer is confirmed, that's when the big guns come out. The staging scans, like an MRI and a PET/CT.
And why do we do all of this? The exams, the needles, the fancy scans, what's the point? It all boils down to one thing, finding out the stage of the cancer. Because at the end of the day, the stage is the single most important piece of information we have. It tells us about the patient's prognosis, and it's what guides every single treatment decision we make from here on out.
Okay, diagnosis, check. Stage, check. Now what? Let's talk treatment. And this is where things get really interesting because it's all about walking a tightrope. On one side, we want to absolutely obliterate the cancer. On the other, we desperately want to preserve all those crucial things that make life worth living, like being able to talk and eat. It's a really delicate balance.
Now, for patients who are lucky enough to be diagnosed with early-stage disease, we're talking small tumors, no spread to the lymph nodes, the first big decision point usually comes down to one question. Do we go with surgery or do we go with radiation? Both can be curative, but man, they come with totally different sets of pros and cons.
So let's break that down. With surgery, the big plus is you might avoid radiation and all its side effects. But the downside? Well, it can change how you look, how you speak. Radiation, on the other hand, is great for preserving the anatomy. You keep your voice box, for example. But it can leave you with some really tough long-term problems, like a chronically dry mouth that never goes away, food tasting weird forever, and major dental issues.
So, and this is so important, this is not a decision that one doctor makes alone. It's a team sport. It requires a whole crew. The surgeon, the radiation oncologist, the medical oncologist, all sitting down together in what we call a tumor board. They put their heads together, hash out the details of the case, and come up with a customized game plan for that specific patient. It's true multidisciplinary care.
Okay, so let's say a patient has surgery. Is that it? Not always. After the operation, the pathologist looks at the tissue under a microscope, and what they find can tell us if more treatment is needed. We're looking for certain high-risk red flags, things like positive margins. That literally means the cancer went right up to the edge of what the surgeon cut out. Or something called extracapsular extension, which is a fancy way of saying the cancer is broken out of a lymph node. If we see those things, we know the risk of it coming back is high, and that patient is going to need radiation.
Now, what about more advanced disease? The game plan totally shifts. For these folks, the frontline treatment is usually a combination of chemotherapy and radiation, given at the same time. Surgery? Well, it takes a bit of a backseat. We often save surgery for what's called salvage, which is basically our plan B if the chemo and radiation don't get the job done, or if the cancer comes back later. So you've gotten the patient through treatment. But honestly, that's just the beginning of a whole new chapter. So for the final part of this explainer, let's look at what happens next. How do we keep an eye on these patients for the long haul? And what do we do if, heaven forbid, the cancer comes back? The follow-up schedule or surveillance is pretty intense right after treatment, and then it slowly tapers off. You can see how it works here. In that first year, you're seeing your doctor every month or two. Why? Because that's when the risk of it coming back is the absolute highest. As you get further out and things are still looking good, those visits get more and more spaced out.
Okay, here is a massive clinical pearl, a really important what not to do. Once you get that first all-clear scan after treatment is finished, you stop ordering routine scans. We don't just scan people every year just to check. It doesn't help, and it causes a ton of anxiety. The only time you get another scan is if the patient has a new problem, a new lump, new pain that makes you worried the cancer is back.
And here's another one in the same vein. We know that radiation to the neck can mess with the thyroid gland. But how do we watch for that? With a simple physical exam and a blood test. That's it. We do not order screening thyroid ultrasounds every year. Again, it's about avoiding tests that don't add value and just create more problems.
So what happens if the cancer does come back? Well, it really depends. If it's a small recurrence right where it started and it's been a while, we might still be able to cure it with another surgery. But if it's come back in a way that we can't operate on, or if it's spread to other parts of the body, then we have to shift gears to systemic therapy. That means treatments that go everywhere, like chemo and these newer immunotherapies. And we have to be honest, in those situations, the prognosis is tough. And that's where palliative care becomes so incredibly important, not just for end of life, but for managing symptoms and making sure quality of life is the top priority.
So let's wrap this up with something for you to think about. This entire field is moving at lightning speed. You've got the ongoing story of HPV, completely rewriting the book on one type of cancer. And then you have the explosion of immunotherapies that are giving us brand new tools. So the real question is, how is all of this going to change during your career? It's going to look really different in 10 or 20 years, and honestly, it's a super exciting time to be getting into this field. Thanks so much for joining me for this explainer.